I want to thank you again for taking time to speak with us today. I'm confident that everything you're going to share today is really going to be valuable for so many in our community, all of those who've suffered from long COVID and are currently really trying to figure out how to manage their symptoms and how they can move forward with these new diagnoses that they may have. And so I first want to start and just really ask you what you feel the prevalence is of patients with dysautonomia who are presenting to your practice. I know you may not be able to speak for all patients, even globally, but just based on what you're seeing, what are you noticing among patients with long COVID?
Yeah. So it's hard to say, as you indicated, because since my practice focuses on POTS, I think people are coming there. They had COVID, they developed problems, and then people suggested they had dysautonomia, and they come to see me for that reason. So the patients that I'm seeing with long COVID, basically all of them have dysautonomia, but again, I think that's because of a referral, bias towards that. I mean, and it's hard to say. I mean, when you look at the literature, there certainly seems to be a lot of dysautonomia, but again, there are centers who have published, high incidence of dysautonomia among long, but those are patients who are referred to a dysautonomia center, so it gets a little tricky. I mean, I think we're going to be learning more as time goes on. I know we're already several years into the pandemic, but
Yeah.
I think a very important thing is going to be to break up. I suspect, well, I would suspect that long COVID is not one thing, and so people, if you took a large number of patients with long COVID, they would have different reasons for having the symptoms that they have. My suspicion is that a big chunk, or maybe most of them, have dysautonomia, or they have um, dysautonomia and conditions that commonly go with it, like mast cell activation syndrome. Again, that's been my experience and the experience of others. There are many, many centers, opening or having long COVID clinics and gathering information. Hopefully, they'll gather the right information, since those of us who work with POTS and dysautonomia, those of you who have dysautonomia, pre-COVID or unrelated to COVID, can attest to how not so well the medical system does at identifying or considering these conditions, considering these diagnoses. Um, we're actually, in the next month or two, at our center, going to be opening up a long COVID clinic where we're specifically,
Oh, that's great.
so we're not discriminating, as it were. We're saying, hey, if you've got long COVID, been diagnosed with long COVID, think you have long COVID, again, whatever that is, kind of do an intake and hopefully sort through. And our suspicion is that most people are going to have conditions that we're already diagnosing and treating, i.e., largely dysautonomia, mast cell activation syndrome. I imagine a significant percentage will have hypermobility disorders like EDS, and then we'll find out. Again, I think there's some patients who clearly had issues before they got sick with COVID, but they weren't problematic, and then COVID served as their trigger, like we see now. People will get, long before COVID, people could get some other viral illness or some other stress to their system that sort of flared up their POTS or dysautonomia. There'll be people, I'm sure, and I've seen people as well, with long COVID, where, you go through, you talk to them, and you can't find any hint that there was a pre-existing condition. And only by seeing a large number of people and sort of gathering all the information can we sort this out. Again, I mean, long COVID is like other diseases that we see, like POTS, like ME/CFS. Again, nobody's really been sure what that is, and you know, in the last few years, we've sort of realized that not all of those people with that diagnosis of ME/CFS have POTS, but most of them, a big chunk of them do have POTS and MCAS, and a lot of them have hypermobility. So, again, I think there's some genetic predisposition to getting certain illnesses after certain triggers, and COVID's certainly a big trigger. And so we're looking forward, I mean, to learning more and gathering information. We're looking forward to, again, we think we can help people. It's the same as POTS. Patients go to doctors and it's like, well, no, your tests are normal, and you're young and you look okay. And it can take a while for people to get the help they need. So sort of what we do in our clinic where we treat people with POTS and conditions like that is, you know, figure out what the best we can. So fortunately, most of the time we do testing, we do evaluation, and we sort of confirm that there's dysautonomia, and we figure out the other pieces. Sometimes, the tests don't confirm it, but we can make a good supposition of what's going on. And the bottom line is we've got strategies for dealing with it. All too often there's this paralysis of the medical system where it's like, well, we don't know which box to put you in, and they spend all their time doing that. And in the meantime, it's like, well, at the very least, you've got migraine headaches. You got a lot of migraine headaches. We know how to treat migraine headaches. Hey, let's at least do that. Hey, you've got a lot of gastrointestinal symptoms. We we have strategies for that. We have tests for that. So I see that day in and day out when I'm talking to patients. And so long COVID is sort of the granddaddy of of lots of symptoms. And so obviously we want to figure out as best as we can, what's going on, try to work upstream to figure out the overarching, if we can, issue that's causing this and sort of address that. But even as we're trying to do that, or even if we can't do that, break it down into manageable pieces. So, oh, you've got brain fog, you've got GI problems, you've got fatigue, you've got headaches, you've got muscle pain, you've got, pain. And again, we've got strategies for treating those things. And so,
Well, we need more centers like that everywhere. But really grateful for what you're able to provide your patient community. Uh, it's it's wonderful. We hear so often that patients, may present with these symptoms and are dismissed, or maybe they're diagnosed with POTS, but they're struggling to get access to testing for mast cell activation syndrome. In an ideal world, we would love for all of that to be under one roof so that patients really can access all of the testing they need. And it sounds like you guys are doing that. So
we are, yeah. It's hard because it's hard to draw nice, clean lines between what's POTS or dysautonomia and what's mast cell and what's being caused by hypermobility. So I'm a neurologist. I started out seeing people with dysautonomia and POTS, and then that led me to the world of hypermobility. And then I'm like, what is this mast cell activation syndrome? And I found myself diagnosing and treating, hypermobility and MCAS because it's hard to find other providers who will. And it's really hard to say, well, I'm just going to treat your POTS because, again, very often I can't treat someone's POTS without treating their mast cell because they're just interwoven. And so,
yeah,
I mean, not every, there are others who work in a multidisciplinary team, but it just, for me and for others that I know who work with MCAS and POTS, you really have to, if you start, getting into bins, I mean, again, getting patient care, if it's through 2 or 3 different providers, is better than them not getting care. But sometimes it's just, it's just a lot easier to, within reason. Again, I need colleagues, cardiologists, I need orthopedists, I need neurosurgeons, I need gastroenterologists to help manage these things. But there's a lot of these symptoms that are so common and so part of, you can't really tease out, and those specialists are sending the patients back to me anyways. So I know we're getting a little off topic, but again, you probably, your listeners have experienced that where the gastroenterologist is like, well, yeah, your stomach's not moving like it should, but that's not a neurologic problem. So go ask your neurologist, and the neurologist is saying, "Hey, what the gastroenterologist say?" And so uh, they're usually saying you got to go back to Dr. Saperstein. So I figure I develop, expand my skill set and toolkit for treating these things. But you definitely need a team of folks to to work with.
Yeah, no, I'm really glad that you mentioned that because I do think that that often can become a full-time job for patients where they're really juggling communicating with all of their providers, trying to coordinate care, sort of getting juggled back and forth to try to find answers. And it's when you find a provider like yourself who's really willing to look at a number of different I don't want to say overlapping diagnoses, but diagnoses that can all be contributing to one another. Um, it really helps a lot. It would be great if that became the standard for a lot of these dysautonomia clinics, where they are able to diagnose all of these other illnesses that are commonly seen within our community. So,
Yeah. Um, Again, there's, the good news is there's not, there's many ways to get the job done as long as the job's getting done. And, that one community may have access, be fortunate and have access to, providers who are knowledgeable about these diseases. I mean, that's obviously most important. If there's nobody in your community or almost nobody who deals with any of these issues, then that's not good. So, as long as there's somebody, but again, either they're working closely together or, they're operating in the same clinic, that's going to be more ideal. But hopefully, over the years, we'll see more of this and people will figure out, optimize ways to deliver this care that's so complex. And
yeah,
there's so many people on the team, PT, OT, just in terms of helping those issues, be it hypermobility or rehabbing POTS. And so we'll hopefully get there. I think COVID, obviously it's hard to say COVID was a good thing in any way, but I think that's gonna help us better understand dysautonomia. I think it's gonna draw better attention to it. I think the community will understand it better. I think, we could go on and list all the downsides or all the difficulties that people with POTS and dysautonomia experience. Certainly one is that, invisible disease concept where, people don't understand. They don't really know what, you talk to your friends or coworkers and family, and they don't really understand what the diagnosis is. They don't understand why you look okay. And last week you went to the picnic and did all these things, and why are you in bed now? And they just can't grasp it, this chronic illness. And so I think you know, it'll help people who don't have long COVID. Hopefully they'll help people who have long COVID. It's unfortunate that, the resources will become available that weren't necessarily available before.